Hi, everyone. Welcome to another episode of the Mission Motherhood Show. I am Cheri Bergeron, the founder of Cheri's Choice, who is bringing this program to you. And today I am really excited to have Dr. Vasiliki Moragianni on our podcast today. She is a double board certified fertility physician, academic leader, and national speaker on reproductive empowerment for professional women, which is a topic near and dear to my heart. She was originally from Greece, trained at Cornell, Drexel, Georgetown, and Harvard Medical School before joining Johns Hopkins, where she serves as the medical director of the Fertility Center and founder for the director of Recurrent Pregnancy Loss, which is such an important topic we're going to get into today. She built her career at the intersection of clinical excellence and physician leadership with experience across academic medicine, private practice, and health system leadership. Through her keynotes and her lead framework, she helps high-performing women transform fertility uncertainty into strategic clarity and helps organizations build cultures where that conversation is no longer has to happen in silence. And about everything that you say in there resonates with me and I know this is how we connected, that professional women really don't get enough information early, and we end up in this cycle of desperation and self-blame and the hope and heartbreak of IVF. And so I'm thrilled that you are coming on to share with us some of a doctor's perspective on all of this.
Yeah, thank you so much for having me. I am thrilled to be here. We talked about our mutual background and experiences, or our common background and experiences, and how they have shaped how we view the world, how we help other people around us. I love all things fertility. I talk about them, raise awareness, treat them every single day. And I think we need to be having this conversation as a normal conversation. There is no taboo. There are no topics that should not be discussed. Surprise, surprise, that's how we all got here. There's nothing, secretive or taboo about it. Every single one of us, I guarantee you, got here through the process of reproduction. So to understand it and embrace it and figure out what is the right timing and the right circumstances isn't even a thing we want to pursue, is extremely important. So we have information and therefore power and control as much as possible, because then there is our body, right? And we do not control everything that happens in our bodies. And that's also another important component. It's not that you did something wrong and that's why you're having difficulty, or you waited too long, or you had that extra piece of bacon or piece of cake or glass of wine. It's because, the same as we don't blame individuals for developing diabetes, we don't say, oh, you had way too many candies, that's why you developed diabetes, or you did something wrong, that's how you developed thyroid disease. There needs to be absolutely no blaming, finger pointing when it comes to fertility. Things sometimes don't work as we expect them to, and we need to understand this up front and be open to understanding ways that we can be helped if that's something that's important to us.
Right, absolutely. And I think I love the notion that we can be proactive about these conversations and that we have a lot of different options to arrive at motherhood. And so we should be thinking about them with the same kind of intentionality that we think about other areas of our life, like our careers. One interesting thing that that I saw in some of your writings was that you mentioned that the infertility rates are 2 to 3 times higher among physicians than the general population. And this was kind of shocking to me, because that's the one group that we actually think probably gets education about fertility, because I don't know anywhere in high school or college, other than perhaps in medical school, that you really understand some of these things. So why? I mean, I can imagine due to the rigor, but why is that, do you think?
You're right. It is surprising, discouraging. It's something that hopefully is changing with time, but my generation and generations before me the conversation was not being had in medical school. You would learn the physiology of the reproductive system. You will learn how the hormones work with each other. Nobody talked to my class. I graduated medical school in 2005. Nobody talked, I mean, I realized this is 21 years ago. Nobody talked to us about freezing your eggs, reproductive environment, reproductive preserving fertility. None of this was a discussion at all throughout medical school, throughout training, because there used to be this mentality of A, it will not happen to me. B, you are become a little bit of a liability the minute a female in medicine starts talking about pregnancy, fertility, pregnancy loss. You are not this person that we can work you to the ground and get as many years and months out of you as we want to. When you are thinking about fertility, you're thinking about fertility preservation, you're thinking about pregnancy complications, pregnancy loss. These are times that you're taken out of the workforce, and we don't like that. But obviously, this is something that absolutely needs to change. It is not okay. And thankfully, I see that it is changing as time goes on. But again, talking about this is extremely important. That's where the conversation needs to start. And I'm sure, and I know the same is true for many other high demand careers. Somebody, an attorney who's trying to be partner or just became partner in a law firm, a woman CEO, a woman, CFO in a large organization, I'm sure are going to be viewed as a liability if they need to take time off to be pregnant, to grieve their loss, to plan their fertility.
Yeah, I went through this. I went through
Yeah.
this very same thing. I think some traditionally male-dominated industries, some very high-powered positions are particularly poor at supporting women in these areas. But I also know I was speaking with a doctor, a specialized doctor recently who was in her mid 30s. And I went to get some assistance and she told me that, oh, I've been meaning to freeze my eggs and this and that. And, and so that's 20 years down the road from me, and we're still seeing those kinds of situations. So while there has been progress, I still don't think it's fully part of the conversation. So, if you could redesign health education in America, what are some of the things that every woman should understand about her fertility before she turns 30, do you think? What's the foundation that we need to know?
Mm-hmm. I think we need to start, and this may sound a little funny, and the first time you hear it, you may think, but then the more you think about it, and trust me, I've tried this with my circle of friends many a times, but maybe even starting with the books we read our children, the fairy tales, right? I'm not saying rewrite everything, but there's no fairy tale where the prince and the princess meet and then they're having fertility issues, right? Or that they need other princess to carry their baby, or they need eggs from another, or sperm from another prince. And I'm not saying let's ruin people's childhoods and scare them, but I'm also saying this is not a thing we ever hear about. And there's books. There's some excellent books about infertility, about donor egg, donor sperm, gestational surrogacy. And right now, I think they're being utilized only primarily by families that have been created with these methods. But I think opening up the conversation a little bit is not a bad thing. Knowing that maybe your best friend was born using a gestational surrogate. It's okay. It's part of life. It's what happens. It's totally fine. Then in school, and I noticed that with my daughter, I have a 10-year-old daughter, and they're getting education about their bodies already and understanding, and obviously little young 10-year-old girls, and I'm sure boys as well, find this disgusting at times, but it doesn't have to be super detailed. It has to be matter of fact, just like you learn how your heart works. This is how the reproductive system works. It doesn't have to promote sexual behavior. It doesn't have to promote promiscuity. It needs to talk about the facts, the birds and the bees, but in a professional way, scientific way. And then after that, in higher education, in college, I speak to college campuses, to graduate schools, to alumni organizations, to medical schools, obviously, law schools, other professional pharmacy schools, and just talking about opening that door. And by opening that door, I don't mean everybody needs to rush out there and have a baby tomorrow, right? For some of us, this may not be the path forward. You may realize you never want to have children, which is fantastic. It's your choice. Take it or leave it, right? But I hate it. Absolutely want to get rid of the people who say, I wish I knew. No sentence in the reproductive realm needs to start with, I wish I knew this sooner. It
Yes.
should always be, I knew, I made my choice, period. My choice and my choice. I like it. I'm happy with it. That's it. Nobody's business. But, I wish I knew this sooner. I wish I knew that this could happen to me. I wish I knew someone like me, whatever that means, has an increased risk of infertility or has an increased risk of complications in pregnancy or pregnancy loss. So, again, opening the door, normalizing the conversation as with anything in life is extremely important. So we feel comfortable talking about it. We ask all our questions and we feel empowered and we say, yep, now I understand what it is. I don't need to be scared or overwhelmed by this.
Right. So we need to normalize this information. We need to have these conversations in many different ways, just the way that, and at different details at different levels. And I agree with you. I think that college is a very significant time when we're thinking about our life holistically and we're thinking about existential thoughts and big ideas. And I think that is a great time to be laying the foundation of fertility education and just simply the idea that we can proactively plan these things. Because for me, because I was not able to find the right person that I wanted to start a family with, I felt really powerless because to me, there was only one model that was going to work. And it was a traditional family with a natural pregnancy. And that's all I knew. And I think that that is a great model. It's just not the only model. And I think that the issue was that I felt trapped in that model and I didn't know that there were other ways. And so I totally agree with you. I know one of the areas that you specialize in is, or that you work in is diminished ovarian reserve, or they call it DOR. And I have seen some research recently that said that there are, that approximately 20% of women who struggle with infertility have DOR, and that statistic is rising. Do you think that this condition is becoming more common, or are we simply getting better at identifying it, diagnosing it, and things like that?
It's probably a combination of the two, also including the fact that we tend to wait longer, right? So it's more likely that you're, unfortunately, I often joke, not jokingly, hashtag patriarchy, right? Women, we're born with all the eggs we will ever have. So that's it. You have your most eggs before you're even born. How am I going to use them when I am an embryo in my mom's uterus? I'm not so sure, but that's when you have your most eggs. And by the time you're born, you have lost a lot of eggs. By the time you hit puberty, you have lost a lot of eggs. And at this point, you haven't even tried to conceive, thankfully. So it's essentially, very simplistically put, just a line that starts really high and then decreases in terms of quality and quantity of eggs during our reproductive years. And the longer we wait in that process, that's why early awareness and discussion of this is important. Unfortunately, you cannot decide when you're 90 to become a mother using your own eggs. And clearly I'm exaggerating, but there is a time limit to this. It's not that anything can happen at any time using your own biological eggs. So the longer we wait in this continuum, the higher the chance for lower egg reserve or lower quality and quantity. It's a natural process that unfortunately cannot be fully reversed. And also, of course, what you talked about, the fact that more patients thankfully understand that these resources are available and they come in and get evaluated, and some of them now get diagnosed with diminished ovarian reserve. And also a combination of many other factors that are affecting, exposures, environmental exposures, other medical problems that can affect egg reserve, because the reproductive system is unfortunately probably the first thing to be sacrifice, so to speak, when something isn't working perfectly in your body. So it's
Oh,
not a vital function, right? If you're being chased by lions in the jungle, your priority is not to reproduce at that time. Your priority is to preserve your heart and your brain and your muscles so you can survive. Um, so the reproductive system is very sensitive to any kind of overall imbalance in your body, because things need to be figured out first before you can bear another, take care of another human for 9 months in your uterus and then outside for much longer. Clearly, we all know exceptions to that, but that's something to keep in mind as well, that there needs to be overall health optimization in preparation for and during pregnancy.
sure. So, when would you recommend that women go and get a baseline fertility assessment? At what age? And even if they're not considering having children at this time, what is a good age to really try to get some of that information?
So just to keep in mind, there is, and this is a very difficult conversation to have with patients, because there is this notion out there that I can go get my fertility checked, similar to how I get my thyroid checked, my cholesterol checked, my diabetes test checked. There's no test that will tell me if you are fertile or infertile, because if we're talking about one person, I'm missing the other half of the equation, right? So if this is a person with eggs in front of me, then I'm missing the sperm part of the picture and vice versa. Also, these tests are not validated to screen for infertility. So I oftentimes tell my patients, when we get a pap test, we're asking the question, do I have cervical cancer? Yes or no? So the pap test is a screening test, that answers a specific question. There's no fertility screening test where I can do this test and it's going to tell me I will have difficulty conceiving when I decide to try with a partner, donor, doesn't matter. Because the diagnosis of infertility is I've been trying for a year and I am not successful. So no test can predict that. So it's important, again, to put this whole discussion in the context of there is no perfect screening test for fertility. We shouldn't all rush out and get our AMH or FSH checked and panic or be totally reassured depending on the result. That being said, having a discussion either with a OBGYN or with a fertility specialist where we just lay out the whole plan, my age, my family history, my personal history, my goals reproductively, test results, all of this in combination, trying to figure out what are options that I have now that I will have in the future, and what can the landscape look like for me. And really, there's no perfect age to do this. Ideally, the younger, the better, but there's no age past which I would say, sorry, no purpose for you to meet with us. There's nothing we can do to help you. And it's also a matter of when is this question entering your mind and your thought process. As I said before, this is not meant to be, let's all go out and procreate and have 35 children each. This is meant to be, here's my options. I understand my body, I understand my limitations and my abilities, and I make conscious decisions with that information that makes sense to me.
Sure. Well, so there are some tests that you can take to understand, to get a sense of ovarian reserve, or, where your hormones are. For me, I remember that my doctor at 40 said, well, your biological clock's ticking a little faster than average, and that sort of thing. There's always the option of egg freezing as sort of one element. And so when do you think is the best time to do that?
Biologically speaking only, the sooner the better. By that, I don't mean when you're 15, but in your I almost said mid 80s. That's not an ideal time. Mid 20s is an ideal time to consider egg freezing. Now, that is biologically speaking, right? There is, however, what makes sense to you. Meaning, if in your early 20s, you're thinking, I don't know which direction my life is going. I don't even know if I want to have children. This is all freaking me out. It's way outside of my thinking right now. Totally fine. But if you're, find yourself in your late 20s thinking, "Ooh, this is something that is a top priority for me, and I want to plan and be as proactive as possible," then you definitely shouldn't wait for any time in the future. Now is always better than any time in the future when it comes to your reproductive potential.
So it's really when you have a sense of clarity about, your desires to be a mother, and then depending on where you are in your readiness at that time.
Yeah.
It seems like those are very key things. So how much confidence should women place in IVF as a backup plan later in life? Because, we're sort of told, well, you've got time and medical science can help you. I mean, that's really what I went through my 30s believing. How is it as a backup plan later in life?
Yeah, it depends. I know this is nobody's favorite answer, but it depends because it varies depending on the age of the egg and the sperm when we're having this discussion, the overall health and quality of those parameters, what you have tried so far. Your 10th IVF cycle is probably not going to be as successful as the very first IVF cycle 10 years ago, right? Or 10 years earlier. IVF is definitely, we have come a very long way in a very short period of time. IVF as a field is younger than 50 years of age, 50 years old. It's, I think, the first baby born with IVF in the world. She's 48 or 49, 48, I believe. So this is how old our field is, which is fascinating if you think about it. I mean, cardiology has been around for centuries and centuries. IVF has not been around for that long. It's been around for less than 50 years, but look at how far we've come. However, we have not come to 100% success rate, not even close to that, unfortunately. And therefore, I would take the approach of, if I need help, or now that I need help, there is this option that can likely increase my chances. I would not take the approach of, I am ready to do something about my reproductive present or future now, but I'm purposefully going to wait because IVF is there and it will work for me in 5 or 10 years when I decide to use it, because there's no guarantee with any of our treatments or any of our approaches. So I would not view IVF that way at all. However, there is a lot that it can offer for a lot of individuals and couples. We have all celebrated millions of very healthy, fantastic babies thanks to IVF, but it's not a 100% guaranteed backup plan for everybody.
Right. So we have to look at it with some degree of pragmatism and realize that it can increase our probabilities, but it's not a sure thing.
Exactly.
Let's talk for a bit about recurrent pregnancy loss. Is that as straightforward as it sounds, that a woman has experienced more than one loss of a pregnancy, or is it more nuanced than that?
No, it's actually exactly that. The definition actually changed less than, I want to say, a few weeks ago. It was in May of 2026 that the official statement from the American Society for Reproductive Medicine, our governing body, came out and said, we used to make this more difficult to diagnose and for patients to seek care, but let's keep it very simple. Recurrent pregnancy loss means I have had at least two, so two or more, anything more than one, losses in the past. In what order, in what gestational age, how they were diagnosed, did I see a doctor for them, did I have a procedure for them, what was the reason for them, doesn't matter. I have experienced 2 pregnancy losses in my life, sprinkled in with healthy pregnancies or not, doesn't matter. I've experienced 2 losses in the past. I get the diagnosis of recurrent pregnancy loss. And clearly it's not about labeling anybody with anything. It's about having more direct access to care, to resources, to possible answers and treatments. And as the founder and director of the Recurrent Pregnancy Loss Center at Hopkins, and in my previous life when I was seeing RPL patients all the time, and that led to my passion for this field, this area of our field, I hear patients be frustrated all the time because RPL falls somewhere in the middle, doesn't have its own space in medicine and OBGYN. Because the infertility diagnosis doesn't cover it 100%. A lot of patients have no difficulty conceiving, yet they cannot have the pregnancy continue to term. Some patients have infertility and RPL, so they struggle, they get pregnant, they lose the pregnancy. Some patients have, it's not given as much weight or recognition as straight up infertility. I never had children. Some patients hear well, at least you could get pregnant. Well, at the end of the day, though, it doesn't make a difference because I'm not holding a baby at the end of the 9 months. So all of that is to say that this newer diagnosis has opened up the door to more patients, if they want to, having access to care, to an evaluation, to possible treatments, so that they can break that cycle of multiple miscarriages, which can be extremely painful emotionally, physically, and can also take up a lot of reproductive time, because each pregnancy, from the time you are trying to you conceive to you lose the pregnancy, you're going back to trying, is probably about half a year, many months out of your reproductive time that not everybody has or is willing to spare, of course.
Right. And we hear, certainly as I've been in this space longer, it can be 1 in 4 to 1 in 5 pregnancies end in loss. And so to some degree, women hear messages of, oh, this happens, it's sort of normalized. But when should a woman seek an evaluation after pregnancy loss? And, and what does that really look like when someone goes through a process to get answers about these losses?
Yeah. So again, and this is something that I've been recommending, and a lot of us have been recommending for several years. But just very recently, ASRM, our professional society, came out and said after 2 pregnancy losses, it makes sense to have an evaluation. And when a couple comes in or an individual comes in to be evaluated for recurrent pregnancy loss, either at our center here at Hopkins or anywhere else, at first everything starts with a very thorough history taking of 2 individuals in the couple, if there are more than one, their family history, their personal history, just asking and understanding everything about them, even things that may sound a little strange or unrelated, not logically related to reproduction, such as some autoimmune components, some nutritional issues or concerns, some family history. So understanding the background and lots of details about these pregnancy losses, the circumstances, any testing that was done previously related to the losses or otherwise. And then typically there's going to be an evaluation, so diagnostic testing to ask questions in terms of what has contributed to these losses. Is there a pattern that we're seeing that because of this one factor being off, you're more likely to have repeated miscarriages than to have a pregnancy go to term? And if that is the case, something is identified, then how can we go about improving our chances, fixing that underlying issue, and therefore improving our chances of having a pregnancy go to term? There is also something that both in the world of infertility and recurrent pregnancy loss is called unexplained diagnosis. So there's unexplained infertility and unexplained RPL. And if I could get my wish in the medical world, it would be to change that name and not call it unexplained anymore, because unexplained gives me X-Files vibes. It's giving me like weird, I'm not sure what's out there vibes, where all it's trying to say is we've done a very thorough evaluation, and good news in a sense, nothing is severely off or abnormal, as opposed to, I don't know what's going on here. We've asked a lot of targeted, important questions, and you have checked a lot of the boxes. That doesn't mean I've asked every single possible question, because I don't know how to ask them all, and I don't have an answer to all of them. But at least I've asked a lot of important questions, and we know that once you get this diagnosis of unexplained infertility or unexplained RPL, the chance of being successful down the road is still pretty high. So the chance of conceiving on your own after not being successful for some time when the evaluation is normal, and the same with having had multiple losses, is pretty high in a subsequent in subsequent attempts, which I try to help my patients see as a positive spin on what unexplained truly means.
I mean, I think that the frustration there, of course, is probably largely an emotional one, because you can say, okay, we can see a lot of good indicators here from a physical perspective, but to not understand the why so that we can perhaps increase our probability really has that psychological impact. And we know that also stress and depression and things like that can also, affect our body. And so with people who have recurrent pregnancy loss, do you really recommend sort of emotional guidance, therapy, support for them in conjunction with the medical things that are going on?
100%. For every single one of the patients that I see, no matter what the diagnosis is, infertility, recurrent pregnancy loss, fertility preservation, anything that we are discussing in the fertility realm, I always discuss, bring up, and offer resources for mental health support through this process. This is something that can very easily mess with you. It can bring on a lot of emotional issues. It can exacerbate emotional issues that are already present. And it's something that needs constant support through this process and beyond. Even when you're successful, patients who have had a diagnosis of infertility or recurrent pregnancy loss, and now they're pregnant and everything is going well, they're not enjoying their pregnancy the same as someone else who never had to deal with this, because they've been conditioned to expect the worst, right? So it's never, and it's probably not until after they are holding their baby in their arms and they know everything is okay, that this trauma still does not go away that easily. And as you're trying, or as you're having repetitive losses, there is a constant repetitive trauma. This is not, one thing happened to you and you get over it, which I'm not saying it's easy to do either, but this is like either every 28 days you get a new hit again, every 28 days your period comes, oh, I failed again, or another pregnancy ends when you should be getting very excited about it, if that's what you want, of course. So mental health support is paramount in the world, in the work that we do. And there's some amazing resources for patients, either locally or nationally, through different organizations and amazing communities that recognize that need and provide great support to patients who really need it. And also this sense of community of you're not alone. You may be the only person that you know of or can think of, or, truly that is open to talking about it in your small world, who is dealing with this. But in the big world, you're definitely not alone. This is very, very common. That's why clinics like ours exist, and doctors like us specialize in this. So it is important to understand you're not alone, have the support. And when I say you, I don't just mean the female going through this, but if there is a partner, male or female, their partner as well, because this is not a one person problem if there's more than one person in the couple. And it's something that I am very passionate about, and I think everybody needs to have constant access to if they want it. I'm not forcing anybody to talk to a therapist, but so many patients feel heard and seen when this becomes an available resource to them.
Sure. Yes. And I think in one of your conversations or one of your writings, you talked about some advancements in the treatment of recurrent pregnancy loss. Are there some new things, some new hope being offered in this area that we should know about?
Yeah, we're always in medicine, and especially in our field, given that it's so young, we always look for more answers, more options that we can offer our patients, more hope, right? And that's why there's constantly research that we conduct here at Hopkins or in many other institutions across the world, research looking at what is causing infertility and recurrent pregnancy loss. What are ways that we can diagnose it earlier or better? What are ways that we can treat it more effectively and increase our chance of success for our patients? And also understanding, I mentioned before, things like the autoimmune component, some of those gray area gray areas in our field where we know there's something there and it makes sense for it to be something there, but what is it exactly and how can I measure it and how can I correct it when I realize that it's off? There is constant research going on in that, and hopefully more and more advances coming out. And also we have been seeing for some years and starting to see even more how these diagnoses, usually given to women at a young age, what do they tell us about you and your body down the line? So when today you're diagnosed with infertility because of diminished ovarian reserve, or you have recurrent pregnancy loss, what does this mean for you when you turn 50 or 60? What do I need to be on the lookout for as your physician at that time? Are you at increased risk for certain types of heart disease, cancers, because of your diagnosis now, and how this translates into overall health now and in the future? So very important that something like that we, is a glimpse into your future health, overall health, not just reproductive health. And we are understanding more and more of this as time goes on. And to me, it's truly fascinating that we can draw this, this correlation from one to the other.
Yes, absolutely. And I think it would be great. Maybe you can recommend some of the research from Johns Hopkins that we can put into some of the show notes, some links there that they can go reference. That'd be great. You talked, so having been in technology myself, and everyone's talking about AI, I saw that you did a post not that long ago about AI's role in patient education. And it was almost a little bit challenging of, what is the role that AI can play in the fertility space? And is it a supportive one when it comes to sort of patient, doctor, and where does it fit in the sort of overall scheme of things? And where can it help?
Yeah, that's an excellent question. A few years ago, a couple of years ago, we wouldn't even have talked about this, right? But this is part of our reality, and it's becoming more and more part of our reality. And I think it is something that we need to embrace to some extent. It doesn't mean that you and I or the rest of humanity needs to be replaced by machines, or I need to ask AI how to express my love to my family or, my loved ones, or how to talk to my patients. But I think because we have so much information literally at our fingertips, more so than ever before, we can use it as a tool. And that's what this research we recently published, and many others like it have shown, and or not many, some others, because we don't have a ton of experience in this field yet. But what we showed is that when patients go to AI, ChatGPT, Claude, Gemini, whatever it is, and you say, I just had surgery, or what should I be expecting? Or I'm meeting with my fertility doctor tomorrow. What questions should I be asking? I think the guidance that is coming out of there is definitely a very good starting point. I clearly am not saying go Google or AI all your questions and follow the answers. I actually think that is not appropriate or safe at all at this point. But for someone who is an engineer, a teacher, a stay-at-home parent, a physician in another specialty, it doesn't matter, an attorney, who does not know 100% what needs to be discussed or asked at the time of a consultation with a fertility doctor, I think having that almost like your personal assistant, where you say, hey, tomorrow I have this important meeting, how should I prepare? That should never take the place of the meeting, but it should be a little, how sometimes important people, they have this person right next to them that whispers something in their ear right before, they take that next step. So I think in that sense, as a starting point and a point of reference and a point of basic general information, that is always double checked and confirmed, it can be very useful. A lot of these disclaimers hopefully will be going away as time goes on and AI gets better and better, because right now I wouldn't trust AI 100% with everything, right? Even with simple things, I mean, simple everyday things. But it is a very useful tool. And I oftentimes see, because we have, for example, at Hopkins and many other institutions, we have an electronic system where patients can send us messages similar to like a Facebook Messenger. Obviously, it's patient secure. And the patient will say, hey, I have a question about this and that. And I can tell oftentimes that these questions were not written by the patient. They were written by AI, because I know how AI writes.
Well,
And,
yes, right.
right. And I also know how my patient talks to me. But I'm actually glad that when I get these messages, because again, it means that the question that they wouldn't have thought to ask me before, AI is helping them to think about, and I'm happy to provide an answer. And if something doesn't make sense or doesn't apply to them, I can say that and we can move on. But if it's something, instead of a patient sitting there and saying, I have no idea, what did you just say to me? Or what should I be asking? What should I be thinking? Again, this is as if you're going to the visit or the doctor's appointment with imagine you're a non-medical person and you bring your doctor friend to the visit with you. They may not be the same specialty as me, but they'll guide you a little bit more than if you brought your singer friend to the consult. It's not going to be as useful, but it would be much more fun for sure. So that's how I view AI. And I think that we need to embrace it and include it, but with a lot of limitations and a lot of provisions, so that accurate information, emotional well-being is preserved.
Yeah, that makes sense. I mean, I think great for exploratory, for some background information. The one thing we should always be have caution around AI is sometimes it will state things with confidence that are incorrect. And so always good to balance that with, expertise coming from your doctor. Just I'm putting my own disclaimer out there too.
Yeah, true.
So I remember that you have created something called the LEAD framework. Can you tell us what that is about and what guidance it gives to women pursuing fertility?
Absolutely. So the LEAD framework is when I speak to professional women, professional organizations, not just the people being affected by it, but the people affecting change in that space, which is extremely important to recognize as well. I use this little acronym of LEAD because most of these people are leaders in their field. And it gives us a little bit of an easy way to remember how we need to approach this. So so LEAD, LEAD. So L stands for learn your biology. Learn your biology. So essentially, as we were talking about before, know your numbers if they make sense to you. Know if and when you're ready to have a baby. When is this important to you? What are your priorities? Biologically, what does this mean to you? How is age important? How are other factors important from a biological standpoint? E stands for evaluate your options early. So figure out what are different options for you. Do you want to pursue fertility treatment to have a baby, IVF, IUI? Do you want to pursue egg freezing, embryo freezing? Just evaluate what the options are out there, but do that early. A stands for align your ambitions. Align your ambition with your timing. So figure out what do I want the big picture to look like? Where am I trying to get to in life, professionally, socially, or otherwise, educationally? And then how does my reproductive planning play into this? And for D is design your support system. So it is extremely important to not go through this process alone for emotional support, but also for logistical and practical support. If you figure out all of these things, but then you're in a very high demand career, and nobody around you supports this or accommodates these needs that you have, then it's gonna be a very uphill battle. So design your support system by creating the systems, putting the systems in place. And again, this is not just, I'm not putting all of the weight on the person going through this, but also the system and the support around them, their organization, their job, their family, their support system, their group of friends, to have this create a little bit of space and support to help them go through this process if and when they decide to do so.
Well, I love that. And I love that you're focusing it so much on what ambitious women need to do to proactively guide themselves to creating the families that they want while they're pursuing their career ambitions and their professional dreams. That's wonderful. Well, I thank you so much for coming on the show today. I think getting this information from a doctor's perspective and someone, who is in a high demand career, I think is really a great example for us to be learning about. So I will leave everyone with this message. If you feel that you were meant to become a mother, I want to encourage you today and tell you that you can absolutely achieve your dream of motherhood. It may look different than you expected, but I always say that with knowledge, courage, determination, all things are possible. And so I hope you will visit Cheri's Choice to get some more information and some resources. And I will make sure to include some of those great links from Dr. Moragianni and from Johns Hopkins. They're doing some great work there. So until next time, take care.
Bye. Thank you.